All right, let's get started. We can expect a few more people to filter in, but we want to honour and respect the people that are with us punctually. So let's begin. Hi, everyone. My name is Ben Corio. I'm one of the team members here at CERSH, which is the Centre for Excellence in Rural Sexual Health. For anyone not familiar, I work out of Wangaratta, but we have team members in Shepparton and Bendigo, and at Parkville as well. It's my pleasure to welcome you all to CERSH's Sexual Wellness Professional Development webinar for September 2023. We host these PD webinars monthly, nearly every month. Well, it's meant to be every month except for January and December. So we do have a couple left for this year, so watch this space if you're not familiar with those. Before we go any further, I would like to offer an acknowledgement of country. On behalf of CERSH, I'd like to acknowledge the Bangarang people of the Yorta Yorta Nation, who are the traditional custodians of the lands that I'm speaking to you from. And I'd of course like to acknowledge the traditional custodians of the lands each of you are living and working on today. We extend that respect to elders past and present, and of course to all Aboriginal and Torres Strait Islander colleagues joining us today. If you could just, it would be lovely if you could sound off in the chat, let us know where you're calling in from. So it's my pleasure to introduce Louise Bourchier as our webinar host for today. Louise is a PhD candidate at the University of Melbourne. She is researching the sexual health needs of people aged 60 plus and is particularly interested in health information gaps and how we can deliver better sexual health promotion for older adults. Louise has spent the last decade working in sexual health programming and higher education teaching, both in Australia and New Zealand. Her favourite thing is teaching sex ed workshops for adult audiences and facilitating conversations about sex and relationships. So just before I hand over, a little bit of housekeeping. We should have time for questions at the end, so please feel free to drop those in the chat as we go or save them for the end. We are also recording this session. So if you'd like your questions to be anonymous, just mention that and I won't add a name when I read any questions out. So without any further ado, I'd like to hand over to Louise. Louise, thank you so much.
Great, thanks Ben, and thanks everybody for coming along. I can see that Sue has already posted a couple of comments in the chat. So Sue is one of my PhD supervisors. But for others who are here, if you want to let us know what your profession is or where you're from, that'd be great. Feel free to drop that in the chat and I'll try. And yeah, it'd be great to know who's in the room. Okay, I'm going to share my slides. And there we go. So I've recently spoken at the Sex Rurality Conference, the CERSH conference in May, and also at the Sexual Health Conference in Sydney last week. So if you were at either or both of those things, you'll see a few slides that are familiar, but there's also some different content in there as well. So welcome everybody, whether you've seen me speak before or not. It's great to be here today with CERSH. So today I'm going to be talking about older adult sexual health. Oh, hang on a minute. Let me get my clicker thing. There we go. It's working. So I'll tell you a little bit about myself, although Ben already gave you my excellent bio. And I'll talk about what we know already about older adult sexual health, and then focus in on what we know in the Australian context. Then I'm going to talk a bit about some of my own PhD research, focusing around STI trends among older women, among older adult sexual health information seeking behaviours. And I'm going to give a sneak peek into an upcoming project I'm going to work on with CERSH. And I'll give you some suggestions at the end for things that you can do to improve access to older adults around their sexual health. So who am I and what am I doing? Again, you already got my bio, but I did my Masters of Public Health at the University of Melbourne, finished in 2012. And since then, I've been involved in higher education teaching in Australia and New Zealand. I taught at the Australian Catholic University briefly. I taught at Unitec in Auckland, and now I'm teaching at the University of Melbourne. I teach on the Graduate Certificate in Sexual Health and the Masters of Public Health programs. Outside of academic teaching, I've been doing community-based workshop teaching for about 10 years. I like teaching content around pleasure and communication, as well as more traditional sort of sexual health, safer sex and STIs. And I'm currently a PhD candidate. I'm doing a part-time PhD, so I'm 4 years on the calendar, probably another 2 to go. So what do we know about older adults' sexual health? So we know that older adults have sex, not all older adults, but many do, and that sex is rated as important by older adults. They consider it valuable and positive for their well-being. Again, not all, but many older adults do. And there are benefits, both physical and psychological, to being sexually active. So there is, however, a general assumption of asexuality among older adults. So people think that older people no longer are interested in sex or not having sex. And therefore, there's that sort of disconnect between what I've said there, that sex actually is important for many older people, but it's kind of invisibilized and often not acknowledged. So let's move on. Sorry, I just got a funny pop-up from something on my computer. All right, here we go to some definitions. So when I say older adults, what I'm talking about is people aged about over 60. My PhD research focuses on those over 60, but you'll find in the literature there's a varying definition of older adults. Some will say people aged 50 and over. I've even seen 40 and over, and some will say 65 and over, or other age cutoffs. So it does vary a little bit, but I'm talking about ages 60 plus, more or less. And regarding sexual health and sexual activity, just to emphasize there that in my presentation today, I'm not talking about a narrow definition of sexual health and sexual activity. I'm talking about a broad definition. So as I go through the presentation today, I'm talking about partnered sexual activity, but also solo sexual activity. I'm talking about pleasure. I'm talking about aspects of relationships and intimacy beyond intercourse and STIs. So what's going on with older adults of today? So we know that older adults today, the baby boomer generation, are perhaps operating in a different context from the previous generation of older adults. And I'm sure every generation has their own context that they operate in. But we can see today that dating and repartnering are quite common. There are things like online dating, which have an impact on how older people are reconnecting and connecting with each other. We know that STIs are going up, and I'll talk a little bit about this soon. There's, of course, the physical changes related to aging, for example, around menopause, and increases around, erectile dysfunction becomes more common as people get older. Also, older people are dealing with medical events and chronic conditions more so than younger people. So, for example, what is the impact on a person's sexual life if they have a heart attack, or if they have diabetes, or if they have high blood pressure, or after cancer, for example? We also know that obviously as people get older and more frail and require more assistance, they're more likely to go into residential aged care. So that means that for those who are continuing their sexual lives, it's quite different from when they were independent in the community. So you can see here that there are contexts that are different and distinct from younger people. We know that sexual health conversations between older patients and their GPs are not all that common in primary care. So GPs are the main place that older people go for sexual health information, for treatment and referral, and STI testing usually takes place in the general practice setting. However, older patients wait for GPs to initiate these conversations, and GPs wait for patients to initiate the conversations. So therefore, these discussions are rarely happening. So we know this from international research. There's documentation of this from other countries, especially the UK, but also in Australia. And there are no guidelines or sort of screening guidelines or sexual health management guidelines or policy for older adults. And one missed opportunity, for example, is that sexual health is not included within the 75 plus health check. And we also know from research that some GPs feel they're not adequately trained. It's not that people are necessarily resistant to discussing these things, they're just not quite sure what to say, not quite sure how to bring them up. When it comes to sexual health promotion or sexual health information, There's older people often had limited sex education when they were younger, and there are few resources targeted to older people. These resources are fairly difficult to find and variable in quality. So yes, most information is for young people, and it may not be relevant or appealing to older users. I've got some examples here of some of the sorts of resources that are available. So you've got a blog post from Bliss, or Bliss for Women, as it used to be called, which is a great Melbourne-based sort of adult store website. So there are things you can find like that. There's a post here from the Huffington Post about STIs increasing in among older people. Update Me is a flyer. It's a bit out of date now, but it's from Family Planning New Zealand. So you do have some documents like that. No Use By Date is a fantastic YouTube series that was created by researcher Alison Rahn. There are some really great videos in there, so I encourage you to check it out if you're interested in learning a bit more. There's also resources like these books, so Older, Wiser, Sexually Smarter, and Naked at Our Age by Joan Price. So there absolutely are resources, but these things are relatively niche and they're quite difficult to find. If you were just searching on the internet for something, it's unlikely you'd strike gold and find these things. So the research in Australia to date, there was a study not so long ago in 2015 called the Sex, Age and Me study. This was a national study of participants aged 60 plus. It was a large mixed method study. So there was a survey component as well as an interview component. So they got lots of really great, rich data from this study. And some of the key findings were that 72% of participants had reported having sex in the past 12 months. There was a good knowledge of STI symptoms, however, a weaker knowledge of safer sex. And 30% of those who were evaluated as being at risk of an STI had been tested in the last 5 years. So not super high, perhaps 30% is quite low for those who could have been at risk of getting an STI. GPs were the most likely place for STI testing and treatment. And there were some barriers to condom use. I always find it funny because a condom is a barrier, but anyway, just the wording there. There were some challenges to condom use, including embarrassment, erectile difficulties, and a lack of safer sex culture. So the use of condoms wasn't so common or normalized among these older age groups. The main sources of sexual health information for participants were the internet and healthcare providers. There was also a variable willingness and experiences of discussing sexual health matters with healthcare providers. So some participants said that they were willing to discuss it. Some said they weren't. Some said that they had had positive experiences. Some said that they had had negative experiences discussing sexual matters with their healthcare providers. So this was quite a significant Australian study that we got a lot of good data from. So the SHAPE project is the immediate predecessor to my own PhD research. It was run by my 3 PhD supervisors. So that's Jane Hocking, Sue Malta, and Meredith Temple-Smith at the University of Melbourne. So SHAPE stands for Sexual Health, Aging, Perspectives and Education. And this was a relatively small scale qualitative study, and it involved interviews and focus groups. And the main focus of the study was looking at that doctor-patient relationship. So exploring a bit more deeply some of the barriers to older adults having conversations about sexual health with their healthcare providers, so GPs and also nurses in the context of the study. And the latter part of the SHAPE project involved developing and testing a tool, which was a kind of a checklist tool. This tool was designed to facilitate conversations between healthcare providers and their older patients. Just give me 2 seconds. I can't see the timer on my computer, so I'm just going to grab my phone and I'll be back in 2 seconds. All right, this will allow me to keep on time. So this was the immediate predecessor of my own PhD research. So just to touch on some other further Australian research, some other studies that I won't mention the studies themselves, but just some of the key findings. Older men are less likely to use condoms than younger men. A few reasons there we could explore. And similarly, older women were less likely than younger women to refuse sex without a condom. So there's also, like I said it before, a bit of lack of policy around older adult sexual health. And there's also, so Alison Rahn, who I mentioned earlier, who created that YouTube series, No Use By Date, also did some more extensive research and concluded that better systems were needed to support couples' intimacy in residential aged care, as this is a very hit and miss domain for couples' intimacy. And often there are barriers. For example, one partner who goes into care and the other still living in community, or potentially partners can be separated within a residential aged care facility, and there's lots of variability around the privacy that residents have access to. So lots of challenges there in the residential aged care context, not to mention the complexities of when dementia is involved. Now, this takes us towards my own PhD research. So one of the studies that I did early on in my PhD was an examination of STI trends among older Australian women. Essentially, what I was wondering was, we know that sexual health is important to many older adults, but I work in public health, and I was like, from a public health perspective, what would be, is there an identified need for more sexual health information or more kind of public health attention on older adult sexual health? So for that reason, I examined STIs among older adults, and for a few reasons I won't go into now, I looked at older women specifically. And so this is a paper that I published along with my PhD supervisors a couple of years ago, and this will have all of the details if you'd like some more information about the study. I'm going to give some highlights now in the presentation. So basically the aim of the study was to investigate STI rates, plus to look at specifically testing and test positivity for chlamydia. I used some publicly available data, and I compared 2 older age groups with 2 younger age groups. And the data came from all over Australia and looking at women only. So I calculated some rates and generated some figures, and I did Poisson regression to explore STI rates and testing and test positivity. So these figures are not the easiest to read. So what I'll just clarify is that there are 2 different scales. So the right-hand scale has the smaller numbers, and that's for the older women groups, and the left-hand scale has larger numbers. This is not always a very clear way to present data, but the reason that I chose this is because what I'm trying to emphasize is the different shapes of the trends of the lines between older and younger age groups. So the older age groups there are in red, and if we look at the solid line and the solid red line compared to the solid gray line, which is the younger age group, we can see that while the younger age group shows that chlamydia was increasing, it then plateaued and decreased. Whereas among the 55 to 64-year-old age group, and also actually among the 65 to 74-year-old age group, you can see that there isn't that dropping off, there isn't that balancing out of chlamydia. So chlamydia continues to increase among older age groups. Like I said, the right-hand scale is much lower numbers. The absolute, the rates of chlamydia are much lower, but we see a continued increase in chlamydia that we don't see among older age groups, where there's a slowing down of chlamydia over the time period of interest. So that's 2000 to 2018. Similar for gonorrhea. So again, there are different scales here, but what I really want to emphasize is the different sort of shapes of the curves. We can see that gonorrhea is going up more sharply among that 55 to 64-year-old age group than it is among either of the younger age groups. So chlamydia testing has increased for all age groups over the 2009 to 2018 time period. But this is what I really want to show you, is that test positivity for older women has not decreased. So what I'm saying here is that testing has gone up for all age groups, and among younger people, chlamydia positivity has declined, meaning that we're testing enough young women now that we're seeing the testing reaching beyond those who are at most risk, so that we're seeing a declining rate in chlamydia. In test positivity, whereas with older women, we're not seeing that decline. So it means that we could be still expanding chlamydia testing a bit further to be reaching people who are at lower risk, and it would still be of value. So just like I said, their STI rates increased most sharply among older women, although the rates are lower, and STI testing is not reaching older women with the same range of risk profiles as it is for younger women who are being reached for testing with a wider range of risk profiles. So I don't want to be alarmist about this. I'm not suggesting there's some giant outbreak of chlamydia, but it's just to identify that there's possibly more need for discussing STI testing among older women, among older patients, and considering it as an option as part of their care. So some limitations, like any STI data, this was capturing only those who were tested, not necessarily true infections in the community. And also the data comes from Medicare rebates, and not all settings use Medicare rebates, but most of them do. So let me tell you a little bit now about another project of my PhD, which was looking at sexual health information seeking behaviours and preferences. So basically with the STI study, I established that, yes, there probably is a need for us to look a bit more concertedly at older adult sexual health. And then I said, well, what's already available for older people? Like where are older adults going when they have sexual health questions? Are they going to their GPs? Are they going online? Are older people looking for sexual health information? If so, what are the gaps in what's currently available? So this was the thinking behind the next part of my PhD, which was to create a survey to explore what are the current sexual health information seeking behaviours of older people, and also what are their preferences going forward so that we can possibly improve the current information that's available for them. So for the study design, so I've already explained the purpose there. For the study design, it was an online survey, which was largely dictated by COVID circumstances because this was 2 years ago. The survey took about 17 minutes. It was using Qualtrics software, and I recruited participants through emails to organizations, through paid Facebook advertising. And the inclusion criteria for the survey were that participants be aged 60 and over and also living in Australia. Okay. Yep. So I was really pleased with the response of the survey. We had 1,470 survey participants from all over the country, which I thought was really good. We initially planned to get 500, so this was a really good surprise. In terms of the gender breakdown, we had a really good balance between male and female participants. This was something I was very pleased about because like the Sex, Age and Me study, which was the earlier Australian study that I mentioned, had quite a few more male than female participants. And so I was really pleased that we got this good balance. There were also people of other genders who completed the survey, just a small number, but they're also included in our gender spread there. As far as the age of participants go, half of them were in their 60s, and the other half were aged in their 70s or 80s, and we even had, I think, 3 or 4 participants in their early 90s. Our oldest was 92, so quite a good range there. There was a good representation of different states and territories. I was really pleased about that as well. The states and territories were more or less representative in terms of the percentages of participants from different places. The only place that was overrepresented was the ACT. So I don't know what's going on there, but we had more participants than you would expect from Canberra doing the survey. And in terms of sexual orientation, most participants were heterosexual, as you'd expect for a general population survey. And around 11% said they were either homosexual or bisexual, and there were also people who identified as asexual or something else. Oops. Okay, so I'm still analysing all of the data, but just a little sneak peek into this. 44% of participants, so bearing in mind there were 1,470 participants, 44% said they had looked for sexual health information since turning 60. So that's quite a few. And, not the majority, but it's quite a few. And 67% said that they had sought this information from a GP, and 42% that they said they had sought this information from a health website. So this is consistent with previous research from the Sex, Age and Me study and other studies overseas, saying these are the main places people go for sexual health information. 59% said they were satisfied with the information they found, which, maybe isn't so low, but it also could be higher. So that's really only 3 out of 5 people said they were happy with the information they found. The other 2 in 5 said that they were dissatisfied, they hadn't had their questions answered, perhaps the information was inappropriate or inaccessible, that kind of thing. When I asked participants what topics they had looked up, they said, they'd looked up or they'd asked their doctor about, they gave me a wide range of topics. And I really want to emphasize how varied this is. So like people at any other age group, older adults had a wide range of sexual health concerns and sexual interests that prompted them to seek information. The most frequently asked about topics were related to sexual function. So things around erectile difficulties and vaginal dryness, those were the topics that were the most common. However, there was a very wide range of topics emphasizing the kind of the complexity and the diversity of older adults' experience. So I did also ask participants about some of the things that they would, I think I might have missed a slide somewhere there. I asked participants about what they would like what helps them feel most confident in the information they find. So what are the aspects that make resources the most trustworthy? And I haven't presented this on the slide here, but participants said that they trusted sources that were connected with a reliable institution. So for example, with a university or with a government department, a relevant government department. They liked when there were authors' names given. So there are a few things that we can bear in mind if we want to make sure that the information we create is credible and reliable for older adults. They did not feel that resources you pay for were more reliable than free sources, which is good. So we know that a freely available source from a reliable agency or organization is going to be relevant for these older adults looking for sexual health information. Okay, so I'll flick now across to some of the barriers that people identified in their ability to improve or manage their sexual health. So this was a free text question I asked near the end of the survey. There were, mostly a large number of kind of quantitative questions where people could click, pick answers. And then at the end, I had several, I think 3 free text questions. What's the most important sexual health issue for you? What are the barriers to you managing, improving your sexual health? And then there was a question around the impact of COVID. So I'm a bit more qualitative in my preferences. So I'm really enjoying analyzing that data at the moment. But this is useful for us because it lets us know sort of areas that we can improve, areas that we can work on to help improve older people's access to sexual health care. So the barriers identified, I've done a fairly kind of, a fairly literal kind of content analysis here of the different themes. So the barriers identified were physical issues, relational challenges, healthcare barriers, personal challenges, and difficulty with accessing information. So I'm going to present now quotes from the participants that exemplify each of these themes. So when it comes to physical issues, so these are some of the things that stand in the way of participants managing or improving their sexual health. I'll just read the quotes here. I think it's really great to bring in the voices of participants. So I'll read the quotes. Partner's erection dysfunction due to medications, vaginal dryness, and tiredness for us both. This was framed as a physical barrier by a woman in her 60s. Infections, says a woman in her 80s. Post-prostate cancer operation, impotence and incontinence, for a man in his 70s. Anxiety about complications of pelvic floor repair. Reduced libido for both partners. On each of these coming slides, I've included the challenges, but then I've also included a a tile in a different color, which emphasizes not so much the challenges, but some of the positives, or kind of the counter narrative, shall I say, because it's not all doom and gloom. People aren't all just having a terrible time and experiencing lots of barriers. People in the survey also emphasize the ways that they're still making the most of their sexual lives. So this man in his 80s says, "No barriers that I can think of. We've been married for 61 years and love each other dearly. Cancer has limited my physical performance after very aggressive chemo." So you can see here the way that people frame experiences in their lives can be quite different depending on their context, their relationships, their personality. So despite the physical barriers of cancer and chemo and possibly other physical challenges with age, this man in his 80s says there's no barriers that he can think of to managing and improving his sexual health. And he's obviously enjoying his long-term marriage there. So in these 5 themes, I've ordered them in terms of the most frequently talked about by the participants. So participants most often said the main barrier for me is this physical issue. And then over the next sort of 4 barriers, they go down in terms of the frequency of how often people spoke about them. So the next one is relational challenges. My wife gets embarrassed talking about it. I feel like I'm too old to start dating, especially as I've now come out. This person gave their gender as pansexual, although that's typically a sexual orientation. They gave their gender as that person in their 60s. My wife is in permanent care with dementia. I feel uncomfortable seeking alternative relationships. That was from a man in his 80s. These are very complex scenarios people find themselves in. From down here on the bottom left, a woman in her 70s says, "My children are very judgmental and have indicated that I am too old to have new sexual partners. Until I met my current partner, the main problem was just finding someone in my age group. Not all old dykes are dead from the neck down, surely," from a woman in her 70s. I love the colorfulness of some of these quotes. And then lastly there, a man in his 70s says, "My wife and I have a great sexual relationship." Looking at some of the healthcare barriers. So I already spoke earlier about some of the challenges to initiating and navigating sexual health conversations between older patients and their GPs. And these quotes from participants really kind of bring to life some of those things that make it a bit challenging. So this man in his 70s in the top left there, "I find it embarrassing to ask my GP relating to erection problems." So that's a tricky one. Of course, sex is a sensitive matter. You know, it's sensitive for people at any age to discuss. But certainly if that sensitivity is compiled with that additional feeling of like, oh, well, you know, it's not really appropriate for older people to be sexually active or sexually interested anymore, it can present that extra barrier for older people to bring these things up with their GPs. In the middle, at the top there, man in his 60s says, "Doctor, very young, specialists are foreigners, no Aussie bloke to discuss with." So you can see in there the age of the age differential between the doctor and patient, as well as a cultural barrier, can make it difficult to bring up sexual health issues. Top right there, "Not always being aware of the issues I can reasonably expect answers for from my GP." So not even knowing exactly what is relevant or appropriate to bring up. So, you know, can you talk about erectile dysfunction? Yes, maybe as a very kind of biological issue, but what about libido, or what about other kinds of issues? Are these things you can talk to a GP about? People aren't quite sure. And in that context of feeling a bit embarrassed and unsure, they're just probably not going to bring it up at all. Down in the bottom left there, "The attitudes of healthcare professionals to LGBTIQ people, asking inappropriate questions, not listening, assuming heterosexuality, etc." This is from a woman in her 60s. So yes, just additional challenges, not only being an older woman, but also an LGBT older person, and the challenges that presents for accessing healthcare. And on a similar note, the person in the bottom middle there, the woman in her 60s, "I've never found a clinician or therapist who is well informed and experienced in working with these issues with women, with older neurodivergent women." So this person here also dealing with some, I guess, some additional challenges as well as age. There's also challenges around being neurodiverse and finding that an extra barrier in accessing sexual health care in the primary care context or with a therapist there. But however, we do have a woman over here at the bottom right. I have a good GP who I would be comfortable talking to. So there were absolutely quite a few comments from people saying, great doctor, no issues. Some people also said, I don't go to my usual doctor when I have sexual health issues. I see someone across town, or I see a different doctor at the practice, or I see someone of my preferred gender at a different practice, that kind of thing. So people had found ways around some of these challenges, and many of them found they did have quite satisfactory, positive relationships with their healthcare providers. Looking now at some of the personal challenges that people encountered. So I'd like more intimacy in my marriage. However, I do not feel attractive and I really don't know where to start, from a woman in her 60s. And next, from a man in his 60s, isolation and disconnection from dating as I got older. How to re-enter the dating and relationship process, sense of declining attractiveness, depression medication, impact on capacity to have an erection. So these are really big barriers in one's body image, sense of self, and perhaps some of the kind of social or relational skills that can help us to have positive intimacy in sexual relationships. Top right there, a woman in her 60s said the biggest barrier for her is recovering from sexual assault. A man in his 70s on the bottom left there, I am unwilling to talk. I can feel the fear rising within me right now, just admitting it to you. I'm still scared to talk openly about sex. It's really interesting what people put into a survey when they can write anonymously. I think this would have been very different if I'd been asking people face to face around their barriers to access sexual health care. And, this quote is really touching, I think, about how that person felt that sort of the safety of the anonymity to acknowledge how scary it is for him to talk about sex. In the middle of the bottom there, I think it is the way I was educated in regard to sexual matters. I have difficulty talking about talking to my wife about my sex needs. And bottom right there, no problems. I've reached a stage where I'm quite open. And there were quite a few, comments of this nature that said, "Oh, at my age, you can't be worried about these things anymore. Can't be worried about embarrassment. Just have to get on with it." So, people had all sorts of different attitudes and personal challenges as they navigated their sexual lives. Okay, and last here, some people spoke about having difficulty accessing sexual health information. I guess this interests me a lot, given that my background is sexual health education and sexual health promotion, and I was curious about what people had to say were some of the barriers to them finding information. So the woman in her 60s there, top left, hard to find relevant information and advice. And then next, I don't know where to find reliable information about female orgasm, from a woman in her 70s. Not sure what is normal for older people to put up with, from a woman in her 60s. So just not even knowing where the compass sits for like what is a possibly addressable health problem, and then what's perhaps something which is not, it's a part of aging that can't be addressed. So not really knowing what's normal compared to what's modifiable. So a woman in her 60s down here in the bottom left, feel older people are invisible with regard to sex, frowned upon or joked about. So it's that sort of feeling of stigma or embarrassment that can be a real barrier for people to look after their sexual health or to prioritize it, because they just feel like, well, older people's sex is a bit of a joke. And I've certainly experienced that as I tell people about my PhD research. People's usual first response is some kind of laugh, discomfort sort of thing. So it's unfortunate that we have these views about older people's sexuality. Bottom here in the middle, my partner and I have a high level of intimacy. However, we don't have intercourse because my husband had genital warts and I don't know if it is an STI and I can catch it. I'm too embarrassed to ask anyone. This is very unfortunate because this information could be really significant to changing and improving this person's sexual relationship, their intimate life. And asking a GP or searching appropriately online could help this person find the information. But you can see here that embarrassment possibly compounded by ageism and stigma, has made this a barrier for this woman to get quite easy sexual health information. And really, concern around genital warts probably shouldn't be significant enough to prevent somebody from having intercourse if they want to. So that's really unfortunate. And bottom here, bottom right, nothing stops me as I know how to research what interests me. So there were absolutely people who said, you know, I know where to go, I know where to look, read books, you know, watch videos, I listen to podcasts. So there were people who were who found it that there was, yeah, they had more ease accessing sexual health information, absolutely, despite the overwhelming majority who said that it was more difficult. Let's look specifically at the rural context, given that the scope of CERSH is specifically rural, and participants on the call today might be working in rural contexts, and there are additional barriers for those who live rurally to manage their sexual health care. So I've just pulled out 3 quotes here from older participants who live in rural postcodes. So a man here in his 60s is probably worried about what GP or others might think locally. So that's that concern about anonymity and privacy. So whether it's a real concern or more of a perceived concern, but just feeling like in a small community, broaching sensitive issues like sexual health, people are worried about their privacy and confidentiality. Top right here. Difficult to find a doctor I am comfortable talking to. There is a shortage of doctors in the area. It takes weeks to get an appointment. My doctor has moved on and can't find another one in the area that I am comfortable with. So the fact that it's difficult, you know, there aren't a lot of doctors and there's quite high turnover of doctors is a barrier to this woman in her 60s managing and improving her sexual health. And down the bottom here, a genderqueer person in their 60s says, I'd like someone professional to talk to about being genderqueer, as local medical people in my regional areas do not accept anyone different. And in a small regional community, privacy is far from certain. This leaves me feeling very isolated and lonely. Okay. So just a bit of a sneak peek. So what we've looked at so far was the initial study that I did looking at STIs. Then I pulled out some of the highlights from the survey that I ran, asking older adults about sexual health information they had sought and barriers they experienced in managing their sexual health. And then my upcoming project is a collaboration with CERSH. I'm going to be working on developing a GP training module, and that's going to happen next year. And as part of that, I'm going to be doing some interviews and focus groups with GPs and older patients in rural Victoria. So keep an eye on this, because this is going to be a cool new upcoming study. I want to get some more information on the specific dynamics between GPs and older patients in the rural setting and ways we can improve those sexual health conversations and sexual health care for those older patients. So this project has been supported by a grant from the Australian Association of Gerontology. So it's really great to see that sexual health is making an appearance in terms of the priorities of what the Australian Association of Gerontology is now funding. So looking forward to getting into that. I've just recently been awarded that small grant. Okay, so what can you do to improve the situation? I've spoken about some of the challenges, I've spoken about some of the barriers. Well, what you can do does depend on what your profession is and what your context is. But here are some ideas which might be relevant to you. So if you do work in a clinical context, ask your older patients about sexual health, and also be prepared when older patients bring it up. Consider STI testing, discuss whether that might be relevant for a patient, and consider the sexual health impacts of chronic conditions, medications, surgeries, and disabilities that are acquired with age. So yeah, sexual health matters to many older people, not all, but it's really important to check in with older patients to see if there are going to be sexual health, impacts of various kinds of medical events and conditions, and to check how a patient feels about that and whether you can help them out with it. So I've written here, like an inverted, in quote marks, the kind of thing that one could say to a patient. So you could say something like, as part of overall care, we ask all our patients if they'd like to discuss sexual health. an introduction like that kind of normalizes that. If there's anything you'd like to talk about, we can do so today or make another appointment. So one of the challenges is that sexual health often doesn't make it to the top of the list. So it might be kind of lower down the list. And then, of course, when you don't have a lot of time in an appointment, you won't have time to address it. But you can always propose to the patient that they can make another appointment, or you could perhaps work with them to schedule another appointment. That kind of statement signals that it is important, even if you can't address it straight away. And just that little bubble up there in the top right, you don't need to know all the answers. It's really just about being somebody who a patient can discuss with. You can say, I don't know, I can seek advice, and you can refer them. We saw there in some of the quotes that older people don't know what it's appropriate to bring their healthcare providers, like what questions they can even get help with. So patients may well bring things that are not exactly, where in the primary care context or healthcare context is not exactly the right place to address an issue, but it can be a place where that concern can be normalized, and you can say, well, look, I'll help you find a place to go, or here are some resources, you can go here, or ring this number, or that kind of thing. So lots of ways we can support our older patients around their sexual health when we work in clinical contexts. For those who maybe work in health promotion or have some kind of health promotion scope to their work, it'd be really great if we could work to create sexual health resources that are relevant to older age groups. So a lot of sexual health information, like I mentioned earlier, is really targeted to younger ages. And so the examples are not particularly relatable for older people. So it'd be great if we could have some examples that were more relatable. Addressing issues that are more common among older ages would also be a really great addition to sexual health promotion materials. So, for example, erection difficulties can complicate condom use, and erection difficulties become more common with age, especially when complicated by chronic conditions and other medications. So I did a bit of a test yesterday. I typed in, how do you use a condom when you have erectile dysfunction? And I typed in various other permutations of that question. I didn't get any information that was appropriate to people who experienced erectile dysfunction routinely and who were trying to use condoms. All I got was, do you, it was kind of like framed as people who lose their erection because of condoms. Some people find they lose their erection when they use a condom. Here are some tips. So it wasn't completely irrelevant, but it was really framed for people who didn't have erectile dysfunction, but who found it tricky to remain erect when they used a condom, which is not the scenario I was looking for. So if I was an older patient seeking that information, I would have just said, too hard, can't do it, doesn't work. There's not a lot of information that's targeted for older age groups. And on that note, a number of participants in my survey said they were interested in knowing more about alternatives to penetrative sex. So we could include some of that in sexual health resources. Another note there I put at the bottom is we could create fact sheets on things, for example, like the lubricants best suited to postmenopausal vaginas. I was just remembering this yesterday. Smith & Kitten is an adult store in Minnesota, in Minneapolis, and they had a very, a staff member who was a real nerd about lube and created this excellent fact sheet, which was all about pH of lube and osmolality, which is to do with the absorption of lube. And it had all this information about the best types of lube for different kinds of sexual activities, and it included information on lube for postmenopausal vaginas. And this kind of information is really useful for people because people do get the advice like, okay, vaginal dryness after menopause, you should use lube. But it's a bit more complicated than that because the actual tissue of the vagina changes. Not all lubes are created equal. Some lubes can be very irritating. There's a real niche for high quality information, which is really targeted to older age, sexually active people. And, not much on this slide, but we could also make more effort to ensure that our services are welcoming to older patients. For example, including signage that indicates that older patients are welcome. I'm not quite sure what that would look like, but I'm thinking about how, you have rainbows to indicate that a service is queer inclusive. There might be ways we can indicate to older patients that it's okay or older service users that it's okay to use the service or to discuss sexual health in that context. So just to wrap up, some of the other quotes from my participants, when I asked them what is the most important thing for you, what is the most important sexual health thing for you, these are some of the quotes they come up with. I just want to leave you with this as a kind of a final comment, just to say that many older people do enjoy and prioritize sexual health, that it is important for people, and to kind of bring some of those voices forward. So these are real older adults in our communities. And so what are they saying? So what's the most important? Being comfortable with whatever sexual activities we, partner and I, can engage in that doesn't hurt and gives us pleasure. Maintaining intimacy despite chronic pain and aging. Having a wonderful sex life with my wife. Masturbating when inclined, and other things like watching pornography to remind myself of my sexuality. Options for sexual activity following prostate surgery and post-surgery issues like erectile function. To be able to enjoy masturbation for many years to come. And sex currently plays no part in my well-being, but intimacy, as in sleeping together, cuddling, does. So these are some of the things that are important to the people in our communities. We've got ages there, 60s, 70s, and 80s, around their sexual health. So let's not forget that. So thank you very much. Thanks for watching, for listening, for participating today, and a special thanks to my PhD supervisors for all of their help and support. There's my email there. There are references on these slides, which I won't go through now, but the slides will be made available to you. So if you want to do your own research and follow up, you're welcome to look through the slides. Thanks, everyone.
Thanks so much, Louise. Fascinating as always, and very well presented. Thank you so much. We've got a couple of minutes if anybody does have any questions. I did see a hand up for a second there. Don't think we can allow, or we can allow folks to talk if you'd like to, or you can just drop a question in the chat and I can repeat it.
Shall I stop sharing my slides?
Sure.